Welcome to this clinical deep dive. Today, we're tackling neurosyphilis, which is the complex and, frankly, often missed manifestation of syphilis in the central nervous system. We're going to break down the diagnostic challenges and the core treatment strategies that are just essential for modern clinical practice. So here's our roadmap. We'll start by defining the disease itself, then walk through diagnostic confirmation, treatment, some crucial infection control points, the severe complications, and we'll wrap it all up with a quick knowledge check at the end. All right, first things first, let's get a really precise definition of the disease. What exactly is neurosyphilis? And maybe more importantly, when can it actually show up? Simply put, neurosyphilis is what happens when the bacterium Treponema pallidum invades the central nervous system. Now, the single most critical point to burn into your memory is this. It is not just a late-stage complication. CNS invasion can happen at any stage of a syphilis infection. You can almost think of the disease progressing on two different timelines. The early forms can pop up within months to a few years. These mainly involve the cerebrospinal fluid space and can present as meningitis or even cause strokes. But then you have the late forms, which can simmer for years, even decades, before they damage the brain and spinal cord tissue directly, leading to those devastating classic conditions like Tabes Dorsalis or dementia. Okay, so we know what it is and when it can appear. So how in the world do we confirm a diagnosis? Well, the answer, as you might expect, is in the cerebrospinal fluid. This is really the central clinical question, isn't it? How do we get from suspicion to a definitive diagnosis? For neurosyphilis, there's no way around it. You have to look at the CSF. And this is where it gets tricky. The CSF analysis is a bit of a puzzle. Sure, you'll often see elevated white cells, pleocytosis, but that's not specific at all. The real linchpin here is the CSF-RPR test. It is highly specific, which means a positive result is a very strong indicator, but, and this is a huge but, it has a terribly low sensitivity. We're talking around 30%. So what does that mean? It means a negative CSF-RPR absolutely cannot be used to rule out neurosyphilis. You know, all this diagnostic nuance is useless if the sample itself is bad. A traumatic lumbar puncture, getting blood in the tap, can completely invalidate that crucial RPR test. And let's not forget lab safety. This is a Category B infectious substance. That means it needs proper triple-layer packaging, and it has to be clearly labeled as a diagnostic specimen. These pre-analytical steps are not optional. All right, so let's say we've successfully navigated the diagnostic maze. We have a confirmed case. Now we have to treat it. Let's go over the standard regimens. For neurosyphilis, the standard of care is a pretty straightforward 3-dose regimen of intramuscular benzathine benzylpenicillin. You're giving 2.4 million units on day 1, day 8, and day 15. But the most important first step before you give a single dose is to consult a neurologist. This is non-negotiable. And what about our pediatric patients? Well, for suspected congenital syphilis, the guiding principle is really one of vigilant, long-term observation. It's all about serological follow-up every 3 months for at least the first 6 months of life. And you need to have a very low threshold to investigate further if anything seems off clinically. Beyond treating the individual patient, managing neurosyphilis brings up these critical issues of infection control and laboratory safety. We have to protect our healthcare teams. Now, to really drive home why pathogen-specific protocols are so important, let's just look at an extreme case. Prions. Look at this. All the things we might normally use for cleaning, soap, ethanol, even boiling, they're completely useless. You need incredibly harsh methods to inactivate them. Now, to be perfectly clear, Treponema pallidum is not a prion, but this illustrates a universal principle. You have to know your pathogen and use the validated decontamination method for it. This brings us to a grim but absolutely essential topic: the consequences. What happens if neurolucides is missed or left untreated? The outcomes are often severe and irreversible. To put the stakes of any CNS infection into perspective, just look at this data from invasive meningococcal disease.
A full 20%, that's 1 in 5 survivors, is left with permanent long-term problems, like brain damage or hearing loss. This is a stark reminder of why we must be so aggressive and timely in managing any pathogen that gets into the CNS, including the one that causes neurosyphilis. And for neurosyphilis itself, the complications are devastating. We're talking about those classic parenchymal forms like Tabes Dorsalis and dementia paralytica. Ocular syphilis is another huge concern, with uveitis being the most common presentation. And of course, there's that pathognomonic sign that everyone learns, the Argo-Robertson pupil, the pupil that accommodates for near vision but doesn't react to light. If you see that, neurosyphilis has to be at the top of your differential.
Okay, we've covered a lot of ground. To help consolidate all of this, let's run through a quick clinical knowledge check. So before we dive into the questions, if there's one single takeaway, it's this. Diagnostic vigilance is everything. The presentation of this disease can be so varied, which means you have to maintain a high index of suspicion and be absolutely thorough with your CSF analysis. And now, for the obligatory moment of levity. What do you call a bacterium that passes its microbiology exam? A cultured microbe. Yes, I know. My apologies. It felt necessary. All right, question 1. A 45-year-old comes in with chronic headaches, some vision changes. What is your primary diagnostic specimen if you're suspecting neurosyphilis? The answer, of course, is B, cerebrospinal fluid. As we've stressed throughout this, the CSF exam via lumbar puncture is absolutely paramount for making this diagnosis.
Okay, question number 2. Which of these CSF findings is highly specific for neurosyphilis, even though its sensitivity is known to be quite poor?
And the correct answer here is C, a positive RPR test in the CSF. Remember, this is our most specific marker. It's great when it's positive, but its low sensitivity means a negative result really doesn't help you rule the disease out. So we'll end with this one final provocative question to take with you into your own clinical practice. Given how subtle the diagnosis can be and how terrible the outcomes are, is our collective index of suspicion for neurosyphilis actually high enough today? Something to think about. Thank you for joining me.